So, Bismillah ar-Rahman ar-Rahim. So, our topic for today is going to be leukemias. So, we're going to cover both we're going to cover both chronic lymphocytic leukemia, CLL, and CML, chronic myelogenous leukemia. As usual, this is from almost all of the information and the data is from up to date and NCCN as much as possible. Okay, so we're going to start with the CLL, chronic lymphocytic leukemia. This is a typical picture of the CLL under the microscope. This is actually an actual patient, one of my patients with the CLL. You can see the cells are mature lymphocytes, but they're all over the place. And so CLL and SLL are the same disease. We're going to talk about that. So when we say CLL, means it could be CLL or SLL, everything the same, even the management. So the pathogenesis of the CLL or SLL, basically this is a disease of lymphocytes, as you already know that. It's disease of lymphocytes. So those lymphocytes, something happened to them. And that could be an antigenic stimulation. It could be changes in the bone marrow microenvironment. It could be genetic changes or epigenetic modification, which is changes to the gene expression of the cell without affecting the actual DNA of the cell. So that's what we call epigenetic modification. So these things, if they happen to the lymphocytes, that will lead to what we call monoclonal B-cell lymphocytosis, MBL. MBL, by definition, means lymphocytosis, absolute lymphocytosis, less than 5,000. So remember that cutoff number, absolute lymphocyte count, less than 5,000, without any clinical or radiographic picture of CLL or SLL. So there's nothing else. The only thing is lymphocytosis that persists for 3 months with the lymphocyte count of less than 5,000. We'll talk about that later again. So CLL, by definition, is the progressive accumulation of mature B cells. If it happened in the blood, we call it CLL. If the accumulation of the lymphocytes happen to be in the lymph nodes, we call it SLL. So it is the same disease. How that happened? It is because those lymphocytes, they lose the ability to undergo apoptosis, and that is due to overexpression of the B-cell leukemia lymphoma 2, which is BCL2. BCL2 is the anti-apoptotic protein. So those cells, they do not undergo apoptosis, which is programmed cell death. You can think of it as those cells, they do not know how to die, because those cells, they should die and new ones should come in. So the CLL or SLL disease means the lymphocytes, they lose the capability or the ability to die, they just persist and accumulate. Again, if the accumulation in the blood, it is called CLL. If it's accumulation in the lymph nodes, SLL, and it is the same disease as you said. Characterized by monoclonality, so either kappa or a lambda restriction. So it has to be monoclonal. That's the key. So by definition, it is a monoclonal lymphocytosis, either in the blood or in the lymph nodes. So CLL or SLL, the lymphocytes under the microscope, they look normal. They don't. So they're different from the acute leukemia. Acute leukemia, you see the blast, correct? Myeloblast or lymphoblast here, but they're not blast. They're normal-looking lymphocytes. So by looking under the microscope, they are normal lymphocytes. They just the number is high of them. The they characterized by the fact that they do not reach the functionally normal B cells. So they're functionally incompetent clonal B cells. Clonal, we said either kappa or lambda restricted. The CLL or SLL divided into two big categories based on the IGHV status. So if the IGHV is unmutated, that is one type of CLL or SLL, or if it is mutated or hypermutated, that's another kind. So the unmutated, remember this very well. This is very important when we talk about CLL treatment. So IGHV, unmutated, bad disease, aggressive. Mutated IGHV is an indolent disease, less aggressive. And by the way, this does not change down the road with the disease course. So from the beginning, it's going to be either mutated or unmutated. It doesn't change. So CLL or SL present typically with an abnormal, CBC with lymphocytosis. It's most of the patients, they present with asymptomatic lymphocytosis. And remember, CLL or SLL is the most common leukemia in adults. So we can see that a lot. We see a lot of patients with CLL, more than actually it's underdiagnosed. It could present with anemia, thrombocytopenia, and the anemia could be autoimmune or due to bone marrow infiltration. It could be patient may present with B symptoms, fever, night sweats, or weight loss, fatigue, and asymptomatic adenopathy, like in SLL. And that's usually the patient tell you that the lymph nodes comes and goes. They wax and wane. May present with symptomatic functional extranodal problem, like if the lymph node block the kidneys, kidney problem, mediastinal or hyadenopathy, may present with respiratory symptoms, and so on. Or may present with recurrent infection, because we said these cells are functionally incapable, or they don't function properly, so they don't produce immunoglobulin, because, as you know, lymphocytes produce the immunoglobulins. So a patient may present with recurrent infection. These are the complications of CLL. You can see the anemia due to hyperinsulinism, autoimmune. You can see thrombocytopenia. You can see infection due to immunodeficiency. Some very rarely patient may present with the spontaneous tumor lysis syndrome, but typically the TLS or tumor lysis syndrome in patients who are treated with targeted agents. We'll talk about that later. Patients with CLL are immunodeficient, so they may develop cancer. So we recommend those patients, highly recommend to undergo cancer screening. Diagnosis of CLL, very simple. The diagnosis rely on the CBC with manual diff. Then you may see cytopenia, anemia or thrombocytopenia, and in addition to the lymphocytosis. Peripheral blood smear, lymphocytosis with smudge cells, or also called basket cells. Very characteristic, not pathognomonic. And the smudge cell or basket cells, basically because the cells are fragile, so they burst very easily, and you crush them when you make the slide, and you see that is how the smudge cells, that's how we get smudge or basket cells under the microscope. Because we could see smudge cells or basket cells in other condition, even in viral disease. So you may see smudge cells. So it is not pathognomonic for the CLL, but it is commonly seen in CLL. Immunophenotype or the flow cytometry, this is the characteristics: CD19, 20, CD23, CD5, which is a T cell marker. They're positive, and CD20 usually is low dim, CD10 and cyclin D1 negative, differentiate them from other lymphomas. Low surface membrane immunoglobulin last week, and we said it has to be a kappa or lambda disease. That's a monoclonality. So the lymphocytosis has to be monoclonal, not polyclonal. Immunoglobulins are low. That's happening in 25% of the patients. Serum protein electrophoresis, you may find an M spike, LDH, beta-2 microglobulin, uric acid, and LFTs are needed for the workup. bone marrow test is not required nowadays. You don't need a bone marrow chemical diagnosis of CLL. But if bone marrow is done, usually it could be either interstitial, nodular, or diffuse infiltration of the bone marrow. Lymph node biopsy, if it's done for the diagnosis of SLL, the pathologist may describe them as pseudo follicles, which is, if it's found, is pathognomonic and diagnostic for SLL. So here the definition of this. This is the exact definition of CLL. It is absolute B lymphocyte B cell lymphocytosis, absolute lymphocytosis of 5,000 or more for 3 months, and with colonality, kappa or lambda restriction. And these are the immunophenotypes: CD19, CD20, 23, and 5 positive. If you that is by definition, that is CLL or SLL. You don't need more than that. Or if the absolute lymphocyte count is less than 5,000, if it is less than 5,000 and without any of the characteristic of CLL, like lymphadenopathy, hepatosplenomegaly, or any disease-related cytopenia or symptoms. So nothing. The only thing, just isolated lymphocytosis of less than 5,000, that's not a CLL. We'll call that monoclonal B-cell lymphocytosis. So, but if you find lymphocytosis of less than 5,000, you do need one of these, either nodal, splenic, extramedullary involvement without cytopenia due to bone marrow infiltration, and so you need a biopsy to confirm that. So if you have those, then you could have a CLL or SLL with lymphocytosis of less than 5,000. And the biopsy should show kappa lambda restriction with the same immunophenotype of CLL, which is the CD19, 20, 23, CD5 positive. And then your diagnosis will be SLL if lymph nodes are involved. So this is a CLL or SLL evolution. As we said, it could be MBL, monoclonal B-cell lymphocytosis. And then with time, it may progress to asymptomatic CLL or SLL, just an abnormal blood count. And then over time, progress into symptomatic CLL or SLL, either B symptoms or cytopenias. And very rarely, CLL or SLL may transform into aggressive lymphoma, what we call Richter syndrome. There are 2 staging systems right here. So the Rice staging system and Bennett staging system. You can see them here. So to treat CLL or many CLL, you do need to know risk stratification by heart. So please follow very carefully for this, because this determines how we treat CLL nowadays. So genetic abnormalities is very important. It's not about the blood counts. It is about the quality of the blood count of these lymphocytes, the genetic abnormalities. So genetic abnormalities involved in cellular signaling pathways of CLL or SLL, which will lead to the development and evolution of CLL or SLL. So that's why we need those for the prognosis, and the genetic abnormalities impact treatment decisions. We'll see that when we talk about treatment. And the genetic abnormalities could be detected at time of diagnosis, or it could be even acquired with disease evolution. So here are some of them. Genetic abnormalities and the chromosomal type of genetic abnormalities are here. The common chromosomal abnormalities, which detected by fish, are deletion of chromosome 13 and trisomy 12, deletion of 11q, and that's present in 10 to 20% at time of diagnosis, and that produce the ATM gene mutation. Patient with deletion 11q or ATM gene mutation by molecular testing, they are considered poor. They have poor response to conventional chemotherapy, cytotoxic chemotherapy, which induce DNA damage. So cytotoxic chemotherapy, they're not a good option for patients with ATM gene mutation or deletion 11q by fish. Deletion 17p also presenting 5 to 10% at diagnosis, and also it could be acquired at relapse. It leads to the production of the TP53 gene, which is essential for apoptosis. So if this gene is not functioning properly, mutated, then the patient lose entering into the apoptosis process, so they don't die, they accumulate. So deletion 17p or TP53 gene mutation, also similar to ATM gene mutation, those CLL with this feature has a poor response to conventional chemotherapy, alkylating agents, so they don't respond well. They don't respond well to the conventional chemotherapy. So you need to remember that. The molecular genetic abnormalities are here. Gene mutation are present in CLL in thousands. This is since the start of the use of the NGS, next generation sequencing. So they found there are thousands of gene mutation. Here are the four most common ones, which present in more than 5% of patients with CLL. The TP53, remember the TP53 is from the deletion 17p. So this is here the gene itself. This is a gene that has come from that from 17pq 17p deletion. Again, full response to chemotherapy, the same thing. So, but here we detect this by molecular testing, not by FISH. Or ATM gene mutation, same thing, full response to chemotherapy. This is another gene mutation, but the top one are the most, they're relevant to the treatment, but those are the common molecular abnormalities in CLL patients. But as you said, there are thousands of gene mutations when we use the next generation sequencing of CLL cells. Another genetic abnormalities is complex karyotypes. So if we find 0 to 10 abnormalities, that's considered not a non-complex karyotype. But if we find 3 to 4 abnormalities, that is clinically relevant only if coexist with a TP53 mutation. But more than 5 or more abnormalities, which is complex karyotype, then that is considered prognostically adverse independently of clinical stage, IGHV status, or TP53. So if you do the cytogenetics and found more than 5 abnormalities, that is considered poor prognostic factor regardless of other features. So these are the prognostic features of CLL. On the left side, in green, these are the favorable, which is a deletion 13, TP53, if it is wild type, normal. Not, so that's good. Intermediate trisomy 12 or normal, even the normal chromosomal normal chromosomes are considered an intermediate prognostic feature. Bone marrow infiltration, the diffuse pattern is bad, interstitial or nodular or indolent course disease. These are the unfavorable. So the bad ones are deletion 17p, of course, along with that, the TP53. So either if you find by chromosomal analysis or FISH analysis, you find deletion 17p, that's enough. But if not, then you may check that at a molecular level, and you may find the TP53 mutation or deletion 11q, and that is equivalent to the ATM gene mutation. Unmutated IGHV, that is not good, mutated is good. So remember, unmutated is bad, mutated is good, or indolent. And remember, the IGHV does not change. If it's present, it doesn't change at relapse. But others, if the deletion 17p or deletion 11q are not mutated at time of diagnosis, it may change at time of relapse. So remember that's very important. So you may repeat this test if something happened, disease progress. You may check to make sure there is no evolution of those genes. These are the others, and the karyotype, we mentioned that more than 5 karyotype changes. So let's just now, with remember all these genetic abnormalities, please focus very well on treatment. And as usual, we're going to have our case. So our patient today is a 63-year-old farmer without a significant medical history, healthy farmer, healthy guy, not taking any medication other than NSAID for chronic back pain. He presented with fatigue, found to have anemia and leukocytosis. He is referred to you for further workup. He told you he is tired by the end of the day, but able to take care of his usual farming work. راجل مزارع شغال full-time job. He denies B symptoms, no fever, no weight loss, no night sweats. So his exam showed stable vital signs are stable. There are small and large cervical lymph nodes, bilateral axillary nodes, 3 centimeters in size, spleen 2 fingers below the left costal margin. So here the lab. So please focus with me on this, because this is going to be a case. This case is going to follow up to the end of the presentation, and we learn from it. So WBC 95,000, the normal is 4 to 10, so high. This is leukocytosis, and predominantly lymphocytes. So absolute lymphocyte count, ALC, or absolute lymphocyte count, 80, hemoglobin 9.8, normal 12 to 16. Platelets count 68,000, normal 150 to 400. So he had the anemia and thrombocytopenia. Renal function normal, liver function, total bilirubin is elevated at 3, mainly indirect. This is the normal range. The LDH is elevated right here, is 1.5 abnormal level, haptoglobin low, and ADT or direct Coombs is positive. His immunoglobulin IgG is 280 with a normal 700 to 1600. So this is our patient. So now this is you have done a CBC and you found lymphocytosis, and this is the peripheral blood smear under the microscope. You can see here at the high power, the lymphocyte is a normal looking lymphocyte, and it's not a blast. This is the normal looking lymphocyte. So by looking, it is normal. And there are many lymphocytes, and these are smudge cells at the bottom side. This is an actual one of my patients with the CLL, and our computer has the capability of collecting this smudge cell together, so you can see them. And this is the smear, as I said, high power, low power, and these are the smudge cell. So now, again, same patient. So you have done flow cytometry and you confirm CLL, again, CD19, 20, 23, CD5 positive, DIM, CD20. So your flow cytometry is classic by the book. It is CLL now. So what is your recommendation for him? So now he is your patient and he asks you, you told him you have CLL, and he asks you what we need to do. So choose the best answer from this. Either watchful observation. If you choose in the chat, that will be good. So we can all share the discussion. Watchful observation, rituximab weekly times 4, prednisone, chlorambucil, IVIG. So which one you choose? Just 1 minute, and if you could choose, just go ahead and choose. This will make us more interactive. So just in 1 minute, if you could choose an answer, it would be great. See someone respond. Number 2. Number 2. One more so you can move forward. So 2 people said we'll do number 2. Okay, so let's just go with our discussion. So people choose rituximab weekly times 4. So let's just see what is it. Okay, so let's go over treatment. So most patients with CLL do not require immediate therapy. So observation, watch and wait is very reasonable. Actually, that's for most of the patients with CLL. Only observation, watch, and wait is the way to go. However, some patients require immediate treatment. Some of those may end up having refractory disease with poor outcome. Prognostic factors are important for identifying those high-risk patients. So in the era of targeted therapy, we will talk about targeted therapy, prognostic factors may guide therapeutic decisions. Poor risk factor like deletion 17p, unmutated IGHV, we don't treat based on those. We know they're bad, but unfortunately, we do not have enough data to support you treating patients on those. Are we helping them or not? We don't know. So if you treat any patient with deletion 17p or unmutated, if you have been asked, you could say the standard of care is not to treat only in clinical trial because we need an answer. Are we helping them or not? So question, why not we should treat all CLL, SLL patients, like our patient? Why we don't treat them? We know they have CLL, but we do not treat all CLL patients. Reason. So a couple of facts and a statement. Even without therapy, some patients may have normal survival rate. They may live on normal lifespan. Patients with CLL or SLL is considered incurable, not cured with conventional therapy, and most patients will relapse eventually, with the only exception if they undergo allogeneic bone marrow transplant. That's very rare. Immediate versus delayed treatment, it has been shown no difference in long-term survival. So if you treat patients early, it doesn't make a difference if you wait and treat them later. So there's no difference. Rare cases of a spontaneous regression has been reported, but we don't rely on that, but it is fact. Some patients, the disease just spontaneously go into, partial remission. So these are the indication. Let's see if our patient fit into this. These are the indication for treatment. So we do not treat all kind of patients. So let's just look at our patient. Worsening cytopenia. When we see patient with CLL, if you see our patient clearly has an autoimmune cytopenia. Remember, the LDH was high, total bilirubin indirect is high, direct Coombs was high, was positive, I said. So he has all the features of autoimmune disease. So when we see cytopenia, we treat cytopenia if it is due to bone marrow infiltration. But if the cytopenia is because due to autoimmune, we treat the autoimmune disease rather than treating the CLL. So that's our patient. So our patient has autoimmune clearly from the lab I gave you. It was an autoimmune anemia and thrombocytopenia based on the lab result that's given. So worsening cytopenia, but we need to rule out autoimmune cytopenia. High tumor burden. High tumor burden described as massive splenomegaly, progressive or symptomatic splenomegaly. Our patient is not symptomatic from the spleen, and we said the spleen is 2 fingers below the costal margin, which is not a 6 centimeter. So it doesn't fit. Massive lymphadenopathy, lymph nodes 10 centimeter or more. Our patient, his lymph node, we mentioned 3 centimeter in the axilla, so it's not bulky disease, so he doesn't fit. If the patient is symptomatic or have due to functional extranodal, so our patient doesn't have that. Renal function was okay, doesn't have any of those. Severe disease-related B symptoms. He did not. He denied B symptoms, our patient. Significant fatigue. Significant fatigue means fatigue that interferes with daily activities and daily work. We said this patient is a farmer. He has fatigue, but he was able to function. So doesn't fit. Progressive absolute lymphocytosis. That is a doubling time of lymphocytes in less than 6 months, but our patient just newly diagnosed. We don't even have him for 6 months, so we don't have that information. So based on this, if you have been asked you again how you treat the patient, just think about it until we get to the answer. So early stage asymptomatic CLL, SLL, Rise stage 3 or less, or BNT stage 1 or B, regardless of risk factor, deletion 17p or unmutated IGHG, we treat them with watch and wait, which is observation. We do lab every 3 months for a year, just to get a sense, the trend of his blood counts, then determine after a year. So any patient with this characteristic, we don't treat them regardless of how high the lymphocytes. We do only lab every 3 months for a year to get to see the trend and the doubling time of the lymphocytosis, then determine the frequency. Poor prognostic factor, deletion 17, unmutated IGHV. If we treat, as we said, we say again, based on clinical trial only, or treat them in clinical trial only. So, but if you have a stage 1 SLL, small lymphocytic lymphoma, still the standard of care is observation. We don't treat stage 1. Stage 1 means just one group of one lymph node enlarged in the neck, under the arm, and that's it. So those we don't treat, observation. But however, if we treat with radiation, if we say, you know what, the patient doesn't like it, just disfiguring, mass in the neck, doesn't like it, and you want to treat them with radiation, if radiation is suggested, then we should do extensive pre-treatment staging. Means even stage 1, we should do scans, we should do a bone marrow to rule out extensive disease before we treat with radiation. So that is if you choose or the patient choose to be treated, then you have that extensive workup. So now we are back to our patient. So you have treated the patient with tapering steroid. This patient does not need rituximab because it doesn't fit in any of the indication for treatment. We went through them. So we don't treat them, we don't treat those patients, only watch for observation. However, because he had an autoimmune anemia and thrombocytopenia, we treat those patients with steroids. So any patient with anemia, CLL with anemia, the first thing to do, rule out autoimmune hemolytic anemia and ITP if the platelets are low. Because if the platelets is low, you know, the rise stage 5 is thrombocytopenia, correct? So if it is thrombocytopenia due to autoimmune, it is not stage 5. No, it's stage 4. I mean, yeah. It goes 0 to 4. We don't stage them at advanced disease. So it has to be thrombocytopenia or anemia, not autoimmune. So if the anemia is autoimmune, it doesn't fit into the advanced disease. It's stage 3, I guess, correct? Yeah, rise stage 3. So it doesn't. So it has to be anemia and thrombocytopenia, not autoimmune. It is due to bone marrow infiltration. Then we treat. So this patient was autoimmune. So there is no treatment for this patient. It's only wait and see or observation. But you treat with steroid. You are not treating CLL, but you're treating the autoimmune disease. So during a follow-up visit, he has lost significant weight. He came back to you with a significant weight loss. You couldn't even tell who is he because of the significant weight loss. And you found he has cervical and axillary lymph nodes, slightly increased in size and number. Spleen is stable. He admitted for easy fatigability and not able to do his farming job anymore. So now he's symptomatic, but he doesn't have big lymph nodes or big spleen, just fatigue and loss and weight loss. His lab now, his absolute lymphocyte count is 178. It was 80,000, so it's doubled now. His hemoglobin again dropped to 9.2. Let us drop again to 73. So he's symptomatic now. So now we can treat. Now we can talk about treatment. So now you have done CLL, FISH, and molecular testing, and here are the results. You found out he had his deletion 17p and TP53 not detected, so he doesn't have the bad one. But he has deletion 11q demutation that's detected, and you found he has high permutation. That's mean mutated. Remember, unmutated bad, mutated good. So remember, he has one bad feature, which is deletion 11q demutation is detected. So someone actually answered that. Number 3, I think that's a steroid. Sorry, I didn't see that. So So these are the result of the fish and the molecular testing. So now, so which regimen would you treat him with? Because now clearly he needs treatment. He does fit on the criteria or the indication for treatment. So which regimen you would use? Would you treat him with rituximab weekly times 4, followed by maintenance rituximab every 2 months for 2 years? Please choose. When you choose, it helps you. Believe me, it helps you. Even if you answer wrong, you remember it better. So rituximab weekly times 4, followed by maintenance rituximab for every 2 months for 2 years. Or would you treat him with FCR chemotherapy? Would you treat him with Venclexta and obinutuzumab? Fixed regimen means Venclexta, you give it for 12 months, obinutuzumab or Gazyva, you give it for 6 months. This is what we call fixed regimen. So this is a 12-month treatment. So would you treat him with that? Or would you treat him with chlorambucil, conventional chemotherapy? So 1 minute or even less than 1 minute, so you can go faster. You can choose a couple of people to commit themselves to an answer. Please, come on, guys. Choose any answer. Is symptomatic? So 2 people answer. Let's see. Number 2, FCR. Number 1, rituximab. Don't answer based on what is available for you. Answer based on science, because you may practice somewhere else. So number 3, Venclexta, Gazyva. Okay. All right. So let's just see. Another one say Gazyva or the Venclexta. Okay, someone said number 1. Okay, good. Good. Yeah, I like participation. That's very good. Okay, so let's just go ahead and see. Okay, so let's just see. Our patient is symptomatic. Remember, keep in mind, he has deletion 11q and he has mutated IGHV. So now, let's talk about treatment options for CLL. So our options are targeted therapy, which is CD20 inhibitors, proton tyrosine kinase inhibitor, BTK inhibitor, BCL2 inhibitor, and PI3K inhibitors. And of course, chemoimmunotherapy, like FCR, and immunotherapy, or high-dose methylprednisolone. Someone, let's see if someone added number 2. Okay, good. So these are the treatment options, and I'll just go over them to see how we select and based on what. So let's just see the chemoimmunotherapy. It is an okay regimen. It is okay regimen. This is used to be the best until the targeted therapy. But so now in the era of the targeted therapy, it is considered a good option in a resource-limited setting without access to targeted therapy. So for example, in Sudan, if we don't have the targeted therapy, Venclexta and BTKI, it is reasonable. But if you have them available, it is not the best option. So it is not appropriate in patient with deletion 17 TP53 mutation. So if a patient has, remember we said deletion 17P or TP53 mutation, they don't respond well to the conventional chemotherapy. So it's not a good option. Or even less efficacious in unmutated IGHV. Okay. So the regimen, the FCR regimen, is considered first line for patients with IGHV mutated, less than 65-year-old without significant comorbidities, because this chemotherapy is toxic. So these are the patients that you could treat. They have to be mutated, so the good ones. So they don't have bad features. Other regimen is BR, which is bendamustine rituximab, or chlorambucil and Gazyva, or obinutuzumab. So targeted therapy, just what other? So targeted therapy, BTK, proton tyrosine kinase inhibitor, BTK inhibitors. There are a couple of them. There are 4 actually now. The covalent BTKI inhibitor, ibrutinib, which is the first that's been come, and next was the acalabrutinib or Calquence. It's better tolerated. So if you're looking for tolerability and a good efficacy, Acala is better. But if you're looking for best efficacy with acceptable tolerability, so then zanubrutinib with Brukinsa is the best. So these are the 3 options for you to use. These are the covalent BTKI. There's the new non-covalent BTKI, which is bertubrutinib. This is a new drug, which is a non-covalent BTKI. BTK adverse effect, all of them share very similar side effects. So you need to be aware of all the BTKI are actually, they may have similar side effect, which is risk of bleeding. So you have to stop any of these BTKI before surgery. So usually say 3 to 5 days or up to 7 days. 3 to 5 days is reasonable before surgery. You stop it because of risk of hemorrhage. So risk of bleeding, atrial fibrillation. So risk of atrial fibrillation for all of them, and hypertension. Avoid or dose reduce with a strong CYP3A inhibitor or inducers. I don't remember all of them. Usually just run drug interaction before you give this drug to make sure they don't interact with mainly cardiac medications may interact with these drugs, so be careful. So this is a CLL-12 trial. It was a phase 3 double-blind placebo-controlled trial, more than 300 patients, asymptomatic, treatment naive. They are ability stage A, so early stage with poor prognostic markers. So they gave them ibrutinib versus placebo. Okay, here are the results. Basically, show that is ibrutinib BTK, the first BTKI did not improve overall survival. It postponed treatment development of active disease, so it helped. It improved at 3 years event-free survival, PFS, and next CLL treatment. Adverse effect are, of course, more, as you said, atrial fibrillation, hypertension, and bleeding. So this is the first study that is led to the approval of the ibrutinib as the treatment for CLL, early stage. Final analysis, 5-year overall survival. The observation remains a standard of care. So with this study, after the approval of ibrutinib, I don't think it's approved based on this, but it was approved at that time. But we found out actually watchful observation is a standard of care for CLL without active disease. So like no active disease, just CLL. Still the standard of care is not to treat, watchful observation. So this is a study comparing ibrutinib versus acalabrutinib. It was a phase 3 trial, evaluate RR clinical trial. They compare ibrutinib versus acalabrutinib head to head, and they found that is relapsed CLL, the PFS is similar. However, acalabrutinib or Calquence has less cardiotoxicity and less bleeding events. So it's more, as you said, it's better than ibrutinib. This is a study published in Blood. It was the Alpine study. It was a randomized phase 3 study. They compare zaprutinib or Brukinsa versus ibrutinib Imbruvica for treatment of relapse or refractory CLL. And here the conclusion of it, but I summarize it here, but that's easy to read. So the zanubrutinib, which is Brukinsa versus ibrutinib, this is just the outline of the study. This is the follow-up of the study. It was a 36-month follow-up. The PFS has in favor of the ibrutinib. You can see the result here. It was 60 versus 43%, and it's all in favor of Brukinsa or zanubrutinib, better than ibrutinib. And even the most common reason for discontinuation, everything in favor of zanubrutinib versus Brukinsa. So this is a head-to-head ibrutinib and Brukinsa, or zanubrutinib. So another group is a BCL2 inhibitor, which is Venclexta or venetoclax. This is another new class of drug. Whenever you hear Venclexta or venetoclax, remember tumor lysis syndrome. Believe it or not, Venclexta or the venetoclax may lead to tumor-like lysis syndrome in hours. 6 hours, you may see cells killed and patient may be in the hospital with tumor lysis. Very potent drug, very potent. It just melt out the CLL, the lymphocytes. So we need to monitor patient very closely and hydrate the patient. Sometimes you may need to put the patient in the hospital for IV fluid when you start and you give the medicine with the ramp up dose. So you give very small dose, like 10, 20, 50, and just increase the dose gradually over 5 weeks because this drug is very potent, may lead to tumor lysis syndrome in front of your eyes. As I said, even 6 hours, you may see the tumor lysis syndrome. So and another problem with this drug is neutropenia, risk of infection, avoid nephrotoxic drug, same thing, the drug interaction. And remember, no live attenuated vaccine should be given before, during, or after Venclexta or venetoclax. So whenever you decide, once you decide to do to give the patient this drug, advise them no live attenuated vaccines. So another group is a CD20 inhibitor, rituximab, Gazyva, or obinutuzumab, and Arzera. So these are the CD20 drugs. I think you're very familiar with rituximab, and so they have the same. The main thing for them is hepatitis B reactivation. So any patient receiving CD20 inhibitors should have serology for hepatitis B viral serology. Basically, hepatitis B virus surface antigen and core antibody. So these are needed. So you don't need the hepatitis B antibody, the surface antibody, because that's due to vaccination. So you need the surface antigen and core antibody because these are part of the virus. These are the side effects. So let's just see a comparison between targeted agents and chemoimmunotherapy. So this is a 4-year follow-up of randomized clinical trials, group of them. So they found that targeted therapy, the 4-year PFS benefit for patients who receive fixed venetoclax and obinutuzumab or Gazyva, and even in favor of continuous ibrutinib. The 3-year PFS and overall survival also in favor of the ibrutinib and venetoclax, which is, so basically the randomized trials favor targeted therapy over immunochemotherapy like FCR or BR, bendamustine, rituximab. So now, previously untreated CLL or SLL, targeted therapy preferred over chemoimmunotherapy. So if you choose to treat, don't use chemoimmunotherapy unless targeted drugs are not available. So what about PTKI versus BCL2? These are the two groups of the targeted therapy. So when you choose, keep this in mind. History of AFib, moderate hepatic impairment, severe bleeding, history of bleeding, or patient on warfarin, venetoclax is preferred over PTKI. So with that history, you choose venetoclax with the obinutuzumab or Gazyva. That's the preferred regimen. Patient with renal insufficiency, use PTKI instead of venetoclax. Patient on a strong CYP3A inhibitors. So basically, honestly, I don't remember all these drugs which are CYP3A inhibitors. So just run drug interaction to choose your medication between PTKI or BCL2 because both of them are effective, but you need to choose the right drug. So what about fixed versus continuous target therapy? Because the initial indication was ibrutinib for, just keep going for life, which is continuous target therapy. And then a study that being done with the fixed fixed time. Fixed means venetoclax was given for 12 months and Gazyva or obinutuzumab given for 6 months. So that's a fixed regimen. So what is the which one is preferred? So let's just compare them. The fixed, which is venetoclax or Venclexta or obinutuzumab or Gazyva, or fixed Venclexta and ibrutinib for 24 months. The first one for 12 months. This for and then it's more intensive therapy, logistically complicated, and the benefit is a treatment-free interval. So it's the fixed, yeah. So 12 or 24 months. So that's an issue for some patients. Continuous, these are the options: zanubrutinib, acalabrutinib, or ibrutinib with Gazyva. So these are your options. So the disadvantage, you have to give this drug until disease progression or unacceptable toxicity. So it's continuous treatment. So now here we say patient with deletion 17p or TP53 mutation. The cross-trial comparison telling us fixed Venclexta and Gazyva, which is obinutuzumab, versus continuous Acala or zanubrutinib. This is for patients with deletion 17p. Continuous Acala or zanubrutinib is preferred. So patient would prefer with that kind of mutation. That's a preferred regimen. But finally, based on the decision is based on patient comorbidities and preference, of course. So you have to talk to the patient. But these are the recommended regimen for patients with the deletion 17p or TP53 mutation. What about the PI3K inhibitors? Those drugs are very toxic. They're oral inhibitors of the PI3K inhibitors, and so those are very toxic. So one of them is Zidelic. Actually, it has been removed from the market, or actually not from the market, but as an indication for the CLL. It has been removed. Don't use it. So it's been recommended, but now Food and Drug Administration removed this indication, so it is not used anymore. The other one is Cobectra, but as I said, these drugs are very toxic. Actually, I've used one of them and just a lot of complications. Even fatal or serious toxicities could happen, which is mainly opportunistic infection, diarrhea, colitis, it's toxic pneumonitis. So avoid or dosage use in patients with this strong CP3A inhibitors or inducers. So hopefully you don't have to use this drug. So prior to initiation, are we doing okay? I think, yeah, hopefully we, I'm not going to go fast. But let's just do go with the prior to initiation of treatment. What you should do before starting treatment for CLL. If available, I would say if available, but that's a must. That's standard of care. Before you initiate any treatment, you should check blood with doing FISH for deletion 17p, TP53 mutation, molecular testing, IGHV mutation status. Remember, we said this doesn't change. So this mutation does not change over time. So if it is done, do not repeat it. This is a one-time deal, doesn't change. However, the other G mutation, they do change when the CLL evolve. So if there is evolution of CLL disease at time of disease progression, repeat the genetic testing, except you don't need the PCR for IGHV if it has been done before, because it doesn't change. The karyotype, as we said before, more than 5 karyotype is unfavorable. It should be a 5 here, missing here. Said 5 or more karyotype complex is unfavorable. It's honestly not most of the people do, but it's better to do it, to do cytogenetics for that. But the main thing is the deletion 17, TP53, that is almost everyone agree that's what has to be done. Imaging and bone marrow test as clinically indicated. So it's not for everyone. So let's just now talk about patient needing treatment. Patient fit on the treatment indication. So if your patient fit on the treatment indication, now we have 3 groups of patients. So now patient has active disease. And this is just a summary of what is active disease means. This is indication for treatment, which is worsening anemia, thrombocytopenia, not autoimmune, not autoimmune. If it is autoimmune, treat with the steroid, but it has to be non-autoimmune anemia or thrombocytopenia. Patient with rise stage 3 or 4, Bennett C, patient with symptomatic splenomegaly more than 6 centimeters below the left costal margin, bulky adenopathy more than 10 centimeters, progressive lymphocytosis, increase of lymphocytes by more than 50% in 2 months, or doubling time in less than 6 months. Extensive lymphocytosis is not an indication. However, if it goes more than 200, there is the risk of lymphostasis or the stroke. So that may be a soft indication. Patient not respond to steroids, of course, for the autoimmune indication, symptomatic or extranodal involvement, blockage to kidney, airways, severe B symptoms, even severe fatigue affecting quality of life. So this, I'm going to repeat them 3 times. So this what active disease means. So once you decide patient active disease and you have done the test that we mentioned before initiate treatment, so this group, patient with deletion 17p TP53 mutation positive, so 17 deletion TP53 mutation positive. So if they are mutated, your options are Ecala or zaloprutinib. This is your first option. If not available, then ibrutinib or a fixed Venclexta and Gazyva is an option, or fixed is an option. So, but non-fixed continuous, that is for the patient with mutated TP53. Another group, which is patient with deletion 17, TP53 mutation, negative, IGBHE unmutated. So it's good for the deletion 17, is not, but it's bad, it is unmutated. So this patient should be treated with the Ecala, with Gazyva. So these are your options. You can see them here. So another group, active disease, but TP53 mutation negative, IGHV mutated. So this is not a high risk patient. So those patients, is better to give them fixed treatment so they can get them done in 12 months or 12 months or 24 months if you use ibrutinib and Venclexta, or the other options. So if you can see here, the chemotherapy become at the bottom of the list. So measurable residual disease, MRD, now become an interest for patients with CLL. You need to treat. We don't cure CLL, but we can reach what we call measurable residual disease. By definition, it's detection of approximately 1 cell of CLL per 10,000 leukocytes. That is the definition of MRD. It is undetectable. So undetectable MRD means less than 1 cell by 100,000 leukocytes. That is the definition of MRD, measurable residual disease. Clinical trials suggest that undetectable MRD in peripheral blood after the end of fixed duration treatment is an important predictor of efficacy. So if you treat patient with any regimen and basically mainly targeted drugs, the fixed duration, if you reach MRD, that is a predictor of efficacy of the treatment. I just share with you here, there is a new test which is called clonoSEG assay for CLL, or it is actually, and it is a B-cell clonality. It is an in vitro diagnostic test that intend to identify and quantify the B-cells receptor in DNA extracted from blood of patient or bone marrow patient with CLL. So that is tell you how many cells left behind after treatment. If it is less than 1 cell by 10,000 leukocytes, that's an MRD or minimal residual disease. This is just one of my patients that I run the test on, and you can see here at time of diagnosis has how many. This is has 58,000 cells. After 2 cycles, drop to 1,000. So if I keep repeating it, it may, hopefully could reach an MRD 1 cell by 10,000. Yeah. So this is so in this patient we found 3 sequences A, B, and C. Those are all CLL cells, and we count them. And then we count after each couple of cycles. And then until we reach, so for example, here you can see 66,000 cells drop to 1,000 after 2 months, I think 3 months, from April to July, 3 months. So now we are back to our patient. Are you ready? So now, so you treated the patient successfully with the fixed Venclexta and obinutuzumab. I think most of you chose that option. That's good. So a targeted therapy with the Venclexta or venetoclax and Gazyva or obinutuzumab, and we gave it to for 12 months. You treat him very well, and he achieved the CR and MRD. So you have been following him up very closely with periodic lab and imaging as needed for 6 years. So he has been doing well for 6 years. Now he presented with worsening shortness of breath and abdominal fullness. Imaging showed significant bulky adenopathy and enlarged splenomegaly. So he had a bad relapse. Lab showed mild lymphocytosis, anemia, and thrombocytopenia. So he had a big relapse. So now, you remember, you have treated him with the Venclexta and obinutuzumab, did well for 6 years, and now he has a relapse. Remember, we said CLL patients, we don't cure them. Some of them, disease come back and refractory. So which test would you would not order prior to starting a new treatment? So here, the test that you would not do. What about a PET scan? Would you do a PET scan? Yes or no? Would you repeat CLL fish assay for molecular testing, the B17 and deletion 11q? Would you repeat that? Would you repeat IGHV by PCR? Would you do a lymph node biopsy? Would you do a BCL2 gene mutation? Which test you would not do? So that means there are 4 tests you need to do, 1 test not to do. Please pick one. I have 1 minute. Good. Yes, right. So we don't repeat IGVHD. We said if it's a one-time deal. So why we do a lymph node biopsy? To rule out Richter syndrome. So whenever there is a progressive lymphadenopathy, we need to do a lymph node biopsy to rule out diffuse lymphoma. That's a Richter syndrome. We do a PET scan, of course, for staging. We do repeat the fish for the molecular testing. We do need that because we said at time of relapse, the patient may gain new gene mutation, BCL2 gene mutation because of the Venclexta. We want to make sure the patient still may respond in 6 years. If he has gene mutation, so Venclexta is out. So we don't do the IGVHD, that's true. So what about relapse CLL? We are at the end of the CLL session. So again, CLL is or SLL is not cured with conventional chemotherapy. Is not cures conventional therapy. Most patients will relapse eventually. Asymptomatic relapse does not necessarily require immediate treatment. Follow up closely for development of active disease. So if you're planning to change therapy at progression, send, this is just to answer the last question, send blood for fish, for karyotype. Do not repeat IGVHD because it does not change over time, so don't repeat it. If progress on PTKI, if the patient received PTKI before, check PTK and PLCG2 mutation to make sure they may respond to PTKI, and consider lymph node biopsy to rule out transformation to Richter syndrome. So now, the last question about this case, your patient is back for follow-up, and here are the results of the tests that you have ordered. again, the PET scan was done, showed hypermetabolic activity, generalized adenopathy, splenomegaly, SUV 8 to 17, very active disease. You repeat the test, and the patient again has the patient now the same thing. No gene mutation for the P17P, 11Q gene mutation detected, so nothing changed, everything the same. And you did a lymph node biopsy, showed pseudo follicle on infiltration by small lymphocytes. So there is no Richter transformation. It's not. So it is still SLL, so no change. BCL2 mutation detected. So now you found there is a mutation in the BCL2. So which regimen would you choose to treat this patient now? So now he has a big progression, not Richter's, and no gene mutation new, but he has BCL2 gene mutation is detected. So which regimen you would choose to treat this patient now? FCR or R-CHOP, lenalidomide, which is Revlimid and rituximab, PI3K inhibitor, Cobectra, PTK inhibitor, zanubrutinib or acalabrutinib, or CAR-T. Oops. So which one you choose to treat this patient who has now a recurrent disease 6 years later and his BCL2 gene mutation? You have 5 options to choose from. CAR-T, number 4, PTKI. One more and we can move. One more, please, one more. Odd number. You can have 3 people choose. Okay. One pick, so we can choose. We have number 5. We have CAR-T and BTKI. All right. Well, let's just move. We have. Okay. Well, okay. Let's just move and see what is the best option for this patient. So second and third line therapy for relapsed CLL or SLL. It depends on prior therapy, of course. And so if the patient has been treated with chemoimmunotherapy, then we choose targeted therapy. Like this patient has not been treated with the chemotherapy, so this is not applicable for this patient. If has been treated with BTKI or discontinued due to intolerance, then you check the PTK and PLCG gene mutation. Failure of PTKI, use Venclexta. If the patient has been treated with Venclexta and obinutuzumab, and then like our patient, then it depends if the relapse is late and our relapse is late, then you check the BCL2 and he's negative and he is positive. So the option is BTKI. So now if we go to this patient, here are the options. Number 4 is the right option, the right answer, because the patient has not been treated with BTKI in the past, and he has BCL2 gene mutation. So the best option is BTKI, zanubrutinib or acalabrutinib. The other 4 are okay options. All of them are okay options, but they are not second line. That's the key. I mean, the CAR-T is the right answer, but it is for patients who failed both. So before we go to CAR-T, before you go to the lenalidomide and rituximab, before you go to the PI3K inhibitor, usually have to exhaust the first line options, which is the BCL2 and BTKI. So before you go to those, so they're okay, but they're later after the failure of BTKI. FCR, R-CHOP are not the best. Those R-CHOP if it is Richter. So So these are the options for the refractory after failing both BTKI and vinclustine. These are options: clinical trial, CAR T. So these are the options, even a bone marrow transplant. So this is just a drug in clinical trial, which is because it's still we don't have the best treatment for CLL. That's a curative treatment. So there are clinical trials. So there is now an ongoing clinical trial for looking for a new drug, which is it is a phase 1 clinical trial on ONO 7018. Basically, they target a protein called MALT1, which is mucosa-associated lymphoid tissue lymphoma translocation protein. MALT1 inhibitor is a phase 1 clinical trial. So, what about palliative treatment? So, if the patient has a refractory disease symptomatic, you could use anti-CD20 antibody, splenomegaly. You could use radiation or surgery if the patient has a symptomatic splenomegaly, unresponsive to chemo or targeted therapy, bulky adenopathy, compromising critical structure like kidney, lung, radiation therapy. And this is the take-home message for CLL, SLL. Prognostic factors are important for identifying high-risk patients and may guide therapeutic decisions. Deletion 17p and TP53 mutation is the single most important prognostic predictive factor for high-risk CLL and help directly influence treatment decision. Do not treat based only on deletion 17, TP53 mutation, only in clinical trial. I think this is the end of CLL. Do you want to go with the CML or up to you? Is a shorter, but it is up to you. If you want to finish it, we'll finish it. If you want to hold, I will hold, because CLL is look like there's a lot of information on CLL, but CML is more kind of a little bit simpler to deal with. So it's up to you guys. If you want to use CML, if you want to stop right here, I'm good. Okay. Okay. Someone said Nagifina. Okay. Sure. So we can leave CML for another time. Any other suggestion? Someone said is fine. I think we have almost 70 minutes or so. All right. All right, so we'll stop here, and we can do this another time. I think we have covered most of these essential sessions. I will stop here, and then from now I'll consider that we're done with the most of the sessions. I think there are other people giving different topics. So from here, I would say just presentation or sessions based on your suggestion and your need. So just let me know if there's anything specific or anything from now on. Just let Salah know, or let Salah know. Salah is organizing this, so we can do more based on the need and your request. Assalamu alaikum wa تصبح